I have named this, I don't know if this is correct, but Peggy was calling it, but the first International Orthostatic Tremor Patients Conference. Oh, I didn't put tremor in there, Patients Conference, because it is indeed international. We have Canada, and I hear Spain, is that right? So I think it's a historic thing you guys are doing, and I think it's so important because, as you know, you are probably the only person in your area who has this disorder. Doctors don't know about it, but when patients get together and band together, it gives we as doctors the impetus to try to put clinical trials or something together, because we say, well, we have enough people where we could actually study this in an organized fashion. So I think you're going to be in the driver's seat to say, yeah, we want to move ahead, we want to do some clinical trials, we want to find new things, and that excites us. So thank you very much. Well, what is orthostatic tremor? And you all know this because you experience it. But what it is that there are bursts of muscle activity in your legs or in other muscles, you feel it in other muscles as well, that come immediately when you stand up, goes away immediately when you sit. And I just made a picture of a leg there, and you can see that it happens when we record in every leg muscle when you stand. And when you look at it, you have almost all had this study here or elsewhere, where they put the electrodes on the surface of your skin and record the muscle activity, and you can hear it going chuk, 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 chuk fast. That's the muscle activity coming out of every muscle that we've recorded, and you can see at the bottom it's 1 second. So 1001, you can see how many of those are occurring in 1 second. So it's almost like a helicopter or a motor, and many people can feel that. They actually feel that. Do you all feel that in your legs when you stand, that rapid, almost mechanical engine in the muscles? That will also happen in your arms when you lean forward. It happens in every muscle. And so people used to think, well, it had to do with the fact that you're standing. Well, what one person did is they put a harness on some patients and suspended them, and it wasn't the fact that they were upright, because when you're suspended, the activity isn't there. It's the fact that you're putting weight on the muscles, isn't it? So you lean on things, you stand on it, it's there, and that's what we notice. So that's the phenomena. Why does it happen? That's the big question. Well, what is the history? Many of you have had symptoms almost as long as this has been known. 1984, when it was first reported by Dr. Heilman, who was in Los Angeles at the time. Our doctor here, and I don't think any of you had seen him, but he was the first one here who noticed it, and he was actually reporting to us about it back in the 70s. That was Dr. Sharborough. And he called it shaky leg syndrome, and sometimes people still refer to it as that. And that's really more what you experience, isn't it? Shaky legs. So what do you experience? We talked about the rapid chugging feeling you're feeling in your muscles when you weight bear. The big problem is unsteadiness as soon as you stand up. Goes away as soon as you sit down. We have seen 148 patients here at Mayo, and Dr. Wilkinson summarized that, and I looked at her data yesterday. All 148 had severe unsteadiness. 90% said the unsteadiness got better when they would walk. Do you notice that? Uh-huh. And that, and we don't understand why that is. Why is it when you walk, things seem better? Thankfully, even though you feel very unsteady, when she looked at it, only 15% of people actually had falls. So while you're feeling unsteady, people are usually agile enough with the upper body to prevent severe fall or injury, thankfully. But it's such, and I would be interested now to hear what you experience, because people who have this have a hard time describing exactly how they feel when they stand, but they know they feel very uncomfortable, and many develop a fear of being in an open place, being in a store, being somewhere where they can't grab things. And that's what a lot of people tell me. I'm afraid to go out. I'm afraid if I can't grab onto something. What is it, the experience of it?
I'm definitely not afraid to go out, but I definitely feel if I'm standing, I do get a bit panicky if there's nothing where I could hang on to or lean against. I definitely want to lean against it, because I just feel like it's hard to explain how you feel. You just feel like your legs won't hold you up. It feels like you have no support.
Weak, okay.
Weakness and kind of
one of the big things that I've done is I've actually built around it, and I just don't do things. From a chair, I would assess whether I'm going to actually attempt to do something at all.
In the studies by Dr. Wilkinson, I hate to say it, but it is true, the disease worsened year to year in most of the patients she talked to. And because of that, there was actually something called a quality of life study, looking at how does this affect a person's life. And while you all look great, and I imagine that's frustrating because people probably tell you that, oh, you look so well, what's wrong with you? That's a frustrating thing. Quality of life with this disease is markedly impaired. It affects every part of the quality of life, physical, emotional, and you're telling me, and this study also showed social effects, that people became much more withdrawn with this illness. And depression was very common, happened in 70% of the patients that they studied.
That's scary, isn't it?
Yeah, but I mean, obviously you're the doers, you're the positive ones, you're here looking for a solution, but that isn't always the case. It's a disease that affects every part of your life. Some people may fall, but again, that's rare, 15% only. And the other thing is you get treated with a lot of medications, and all of them have side effects. All of the ones that we use have side effects. So who gets orthostatic tremor? And this is something you all probably are wondering, are my children going to get it? Is it inherited? Very rare. So there's, I think, only 2 cases where there were brothers or twins who got it. It's not inherited. Onset is usually when we're beyond the age of 50, although I was looking at Dr. Wilkinson's data. We had a young girl, 14 years old, who developed it.
That's right.
Yeah. Usually when I'm looking at you, all of you got it probably about age 50 or thereabouts. Yeah. And as I said, it's not diagnosed for 6 years, and people are usually diagnosed with a lot of other things, and the things that you've mentioned. 75% have no other disease, although many will have a little bit of tremor in the hands. And we don't count that as an additional disease. But 25% will have orthostatic tremor as part of some other disease. And looking here, I don't think that's any of you, but when we see a person in the office who has that, we look for some other things. These are the things that we look for. Some people who have orthostatic tremor also have Parkinson's disease. That's the most common additional problem, none of you. Other rare things can be a brain lesion, especially in the cerebellum, and we'll talk about that again, thyroid disease, and some people think that there's inflammatory diseases of the nervous system that can cause orthostatic tremor. All of those rare. The most common thing is a patient might have orthostatic tremor and Parkinson's, and we have about 10 of those in our 148 patients. This is the upper part of the brain that is called the cerebrum, and this is the lower part of the brain that's called the brainstem, and this is the cerebellum. We know that in most tremor disorders, it's something along this pathway that causes tremor. The pathways to the legs are really right here in the middle of the brain. The brain transmits its impulses down, and it gets information from this central part, which is the thalamus, where deep brain stimulation has been performed most often. And this is the balance center, the cerebellum here, okay? And then below this would be the spinal cord. And you've all asked the questions that we ask every day. Where in the brain does this tremor come from? What's the site? What's the place where it's abnormal? And what neurochemicals or neurotransmitters are out of balance that would cause this? That's what we ask all the time, because we think, boy, if we could answer those questions, then we might have more effective therapy. And those, we're looking at it a certain way, other people look at it other ways, but there are people looking into this. I know that was a big question you had, Peggy. Where are they doing research on this? Where does it originate? Most of the studies that are done, and they're sort of indirect, and Helen, you mentioned this, suggest that it's coming from the cerebellum. That's this lower balance portion of the brain down here. And they've done it by stimulating that area and seeing that they could stop the tremor for a little bit. There have been some what we call imaging studies, functional imaging studies like PET, which have suggested an abnormality there. Far from conclusive, but that's a suggestion that that's the part of the brain it originates in. What neurochemicals seem to be out of balance? This is totally unknown until we get better studies. But these are the ones that are suggested. Dopamine, which is the chemical in Parkinson's disease, but we know the vast majority of patients with orthostatic tremor don't have Parkinson's disease. And a chemical that's called GABA, G-A-B-A, which is an inhibitory chemical in the brain, a neurotransmitter. It's very prevalent throughout the brain, very prevalent in the cerebellum. and it presents, if you think about it, sort of a calming influence on the brain. Is there some abnormality there that lets this tremor come out? And you all recognize a lot of these drugs. The one in Dr. Wilkinson's study that was most effective is clonazepam. And I suspect that every one of you has been on that. About 20% of patients get a marked improvement with clonazepam. Most get a little bit, but not marked. And then I would say about a third don't get any response at all. Other things that have been tried, primidone, gabapentin or Neurontin, Lyrica, I know some people have tried, Zonegran, Keppra, all of those work on GABA. They are medicines that are we try, and probably a lot of you have been on those. One thing that happens with orthostatic tremor is you get on a lot of different medicine. So what about surgery? I think Peggy was interested in that. Are there surgeries that have been helpful for orthostatic tremor? Well, there's one report of several patients who got spinal cord stimulators. Sounds a little bit like what you're saying about Klonopin. The patients said they felt a little better, but when they measured their tremor, it was the same. But they felt better, they were able to do a little bit more. They didn't have side effects. The stimulator goes on the back side of the spinal cord. It's been used many years for pain. You don't really feel it, maybe a little tingling. We've not done that, but that's in the literature. What about deep brain stimulation? And we still haven't done this yet. We're waiting for somebody to report it. At our meetings, there are rumors that 2 patients have had it. I don't know if anybody on your website has mentioned it. But since it hasn't been reported in the literature, we always assume that that means that it probably didn't work very well. So we're not enthusiastic to go on and do it until at least somebody says that it works, and we haven't heard that. It's a big thing to do. What about research? What would help us? Well, there are some places in England, you mentioned, where are they doing it? In London, they're doing imaging studies to try to find the tremor source, or using imaging chemicals to find the chemicals that are involved in orthostatic tremor. That's called functional neuroimaging, PET or functional MRI. That may pinpoint for us where the area is that's affected. What we are doing here, and Peggy knows this better than anybody, she's done it twice for us, we're doing what are called brainwave or EEG studies. My fellow, Dr. Melinda Burnett, and Peggy worked together all yesterday afternoon, and Melinda was very, very excited looking at the data she recorded. She came and talked to me last night. But we're trying to use the EEG waves because we think we can find 15, 17 hertz spiking in the EEG that goes along with the tremor. And we're hoping that will pinpoint for us a spot where things might be going on. People would like to do drug studies to find new effective drugs, but in fact, there are none now, and there never have been drug studies for orthostatic tremor. What's the reason for that? Well, I think the big reason is, what does a drug company look for first when they're trying to develop a drug? Yeah. Are there 8 million people with hypertension of this sort? Well, they'll develop a drug. When there are this many people with orthostatic tremor, they're not gonna look.
People would you say that you would